Well, thank you all. Amazing comments. I'm sitting here with way too many notes and way too many questions, but I want to take advantage of my 5 minutes of testimony. Moderation. That was a bad joke about last week's congressional hearing. I'm a product of the Flintstones and the Jetsons, and always thought, and I think growing up, thought that technology was going to be the answer to a more efficient system, a way to share information that was really going to make a difference in, obviously for patient outcomes. But I think what we're hearing in this day and a half is maybe we've hit that sort of friction point where the technology is actually impacting providers in a way that may not always be positive and may not be building resilience and may become less effective. And so maybe we're at a point where we need to be looking at how best to integrate technology into the cancer care continuum for providers talking to providers, for providers talking to patients, and to caregivers. So I just see that as a sort of an overarching sort of that high view. I also want to take advantage of being able to ask a question or two, so if you don't mind, I will. And Courtney, my first question is for you and for others on the panel who would like to contribute. We've talked a lot in the last day and a half about family caregivers, and often the fact that they're under-recognized, underutilized, and not always incorporated into the care team, and the fact that they're really not reimbursed for the amount of work beyond just gasoline and transportation to get family members into the system. What higher levels at policy, at regulation, at reimbursement can we offer family caregivers to support them, not just personally, but even financially?
It's a great question. Well, we know we're moving to bundled payments, so it does change this idea of you could actually bill for an encounter with a family caregiver. If the team talks to a family caregiver and spends time, they should be able to be reimbursed for that. So moving to that bundled payment model, it's more recognizing interacting with the caregiver will ultimately help improve patient outcomes. But going back to your question about the real policy level of that, there are a lot of initiatives to try to accommodate the caregiver dual tasks of working still and also providing care. That's in things like paid family leave or small tax credits that actually are pretty modest at a state level. And also the majority of states in Medicaid allow you to reimburse a caregiver who's taking care of you as a part of consumer-directed care. So there are ways to pay caregivers, but it's really the exception. Some of our group's work has found that only 3% of caregivers nationally receive any kind of support or program. So it is really minimal at this point. Obviously, employers are starting to make changes on their own, things like job flexibility, thinking of their own, Netflix just passed a paid family leave benefit for all of their workers now, whether anyone's taking advantage of it to care for a loved one. Because of that culture, we don't know the valuations of that yet, but there are movements in the private sector too that recognize the lost productivity that they're facing from caregivers. So those are some of the ideas, but I mentioned it yesterday briefly, but this idea that if caregivers leave the labor force early, they have really long-term ramifications in their old age, and some programs that other countries do are things like pension benefits for the time that you spend caregiving instead of working in a productive job because you aren't doing, building up your full retirement savings. So those are some of the policies that have been batted around, and there are special benefits in the VA program, like paying stipends directly to compensate people for their time. Mm-hmm.
So just a comment. I think in the employer environment, one of the things that may begin to shape these kinds of benefits is the low unemployment rate. And if the low unemployment rate continues and employers are competing for a talented workforce, I think we will begin to see, we see this in nursing all the time. When the market is tight, then hospitals offer all sorts of incentives. Unfortunately, they take them away when they don't have recruitment problems. But overall, with low unemployment, this is when employers are going to start doing those kinds of things. So Those, I would hope, would be sustained, though, over time, not the yo-yo that we get with nursing.
Great, thank you, Brenda. I have one more question, and then I invite whoever would like to come up and ask questions as well of this outstanding panel that we have here today. So I was, as a nurse practitioner myself, I was listening to Mark and to others over the last day and a half, and hearing about your innovative models, Skip, and how we use nurse practitioners, talking about survivorship yesterday. How are we going to address the issues of operating to the top of our practice if we have different regulations across states? And this includes how we would use telehealth interventions to be able to reach patients who are maybe either more remote or across state lines. I think Intermountain Health is one of those sort of across state lines. Certainly, Sarah Cannon is. How are we going to address the issues of APPs when we see 81% of practices now are using APPs?
It's a really great question. I know living in Utah, living in Salt Lake City, we have to cross those state lines sometimes. And so as it sits right now, we end up just licensing in multiple states. But when it comes up, it's a lot of cost and a lot of effort to get licensed in another state to take care of a patient and then not use that license again for a long time. So I think the licensing compacts that allow for licensed providers to practice across state lines are very important. I know that in nursing that's already happening in the Intermountain area. I think that that's certainly a policy issue that we need to address. And the compacts are the best solution that I can think of.
Okay, I lied. I have one more question. Oh, go ahead, John.
I was just going to add, I recognize that state laws and a lot of states govern the issues that you just described, but I would also put in there JCO and the compliance culture that is within each of our institutions, often interpreted differently. And I've run into this as I transition from one hospital system into another, and same rules, but they point to the same regulations, but interpret things far. And that's affected our APPs and NPs being able to sign off on chemo after cycle 1, which was commonly done in my practice and the like, but is no longer allowed in my institution. Nursing is the same way. So I would put forward to you, from a policy point of view, clarification more universally of the accreditation guidelines would be helpful.
Yeah, and I would just add, I think that it would be the professional societies, ASCO and the other professional societies representing other disciplines for nursing and social work, et cetera, should really have a vehicle for national licensure, whether that's a different training or a different test or whatever it is, but just to make it's happening. People are doing it under the radar, and they're finding ways within their states or their institutions to make it happen. So we should just find a way through professional training to enable people to get these licenses and do what they're already doing and not have to hide or be shielded.
John, your comment about the difference of interpretation of policy just made me have an aha moment that I don't know that we have risk managers sitting in this audience. I don't know that we have the legal officers sitting in this. And when it comes to credentialing and interpretation of things, they are often the interpreters of that. And so there may be, when we talk about team-based care, hadn't thought about this, but there may be the need to bring, I think there is the need to bring those individuals in. Because in a state where there is that regulation that's written sometimes not as clearly as you would want, it leaves things open to interpretation. And so these risk manager legal advisors may not be as aware of trends that have occurred within the same state with that regulation, and that it is more of a standard practice other places. So we may have another community we need to pull into our discussions.
That's a great point, Brenda, and actually leads into my next question. I promise that'll be my last one, and then we'll go to the mics. We've been talking a lot about using telehealth technologies to reach patients, to reach other clinicians, but particularly for patients, for people with cancer. How are we going to pay for that? What does that look like? And Ron, I'm kind of looking down there towards you, in a bundle payment in an oncology care model.
I'm vague on the current rules of telehealth. That's not part of CMS that I work in, but in a bundled payment system, it doesn't matter. You get paid X dollars for taking care of this patient for 6 months, and however you take care of them is completely fine. You stop to worry about, can I get paid for this? Can I not get paid for this? You do what's right for the patient, which is why I think, bundled payment system is really a nice way to go. And it's better for the physician, right? So I think one of the things I think Larry or somebody mentioned earlier was how much time people spend in pre-auth, in pre-authorization. And if you're in a bundled payment system and somebody says, we're giving you this much, and I always emphasize it should be a fair amount, we can argue about what fair is, then you no longer have to worry about pre-authorization. And I think especially in oncology, where every human being with a cancer has different set of values and goals and what they want to achieve, I think having the ability to just do what's best, in that individual patient-physician relationship is best, rather than working on, well, I really want to do this for you, but I can't get paid for it. And I think one of the examples I was using just in one of the hallway conversations this morning was that sometimes it's worth it as a practice to spend $50 for a cab ride for your patient to get into the office at 2 o'clock in the afternoon to avoid the ER visit and the subsequent hospitalization. In a current system, you can't do that. In OCM, you can with waivers. You have to make the lawyers happy. But in an episode-based system, you can do those kind of things that make sense from a physician-patient standpoint, but may not, may cross over legal boundaries.
So could I follow up on Ron's comments? So Ron, as I think I'm a great believer in alternative payment models because I think our current one has many faults, as you and others have described. But I just want to thank the panelists because I think there are many, many great suggestions here, and this is linked, so bear with me. But what was not always clear in your remarks is we know what to do, but how are we going to get there? How is it going to happen? We know what the best roles of APPs are, but, how can we turn around in 2 years and see a different practice model than we have now? Knowing what we think is the right thing is different than causing it to happen and happen in a reproducible and sustainable way. And one of the ways that that's always happened in American medicine is by payment being a driver. That's driven a lot of what we do, for better or for worse. And though I'm a great believer in alternative payment models, and I think the oncology care model has been a terrific experiment, it's been challenging in cancer. It's much easier to have a bundle for a hip replacement or a cabbage or things I actually don't know anything about, but, episodic components of healthcare that have a very defined beginning and end, whereas cancer is a longitudinal disease, often goes on for many years. And during those years, the treatments that we have to offer the patients change, sometimes quite quickly, with tremendous financial implications. And so, I would argue that that oncology is particularly challenging for an alternative payment model, or we would probably have a bundle for all of cancer like we do for hips or whatever, areas, again, that I don't know much about. And we've bitten it off a little bit. Even the oncology care model has got a bundle for just a component of cancer care. And there's a lot of stuff that happens to the cancer patient that's outside of that bundle. So it's a step, But my question is, if any of us are around and come back in 10 years, are we going to be entirely in that canoe and not in the two canoes, 1 foot in each canoe, which has become, increasingly challenging for us on the provider level to manage. And I worry about the pace of change. And when the pace of change is slow, it usually means that there are real obstacles that we need to figure out how to overcome. So I agree with you, but tell me how you might accelerate the change to a truly bundled cancer program that, if you want to cover all these things, it's got to be the whole cancer episode, not just, 6 months of a chemotherapy episode.
Is that all?
And that's a rhetorical question. So, I realize nobody has the answer to this, but are you optimistic?
I mean, to make an omelet, you have to break some eggs. And I think oncology is a particularly difficult area to have bundled payments because of the cost of drugs and because the standard of care is changing so rapidly. So, one of the things we talk about is, you have checkpoint inhibitors right now that are $15,000 a month that help define the cost of care. Tomorrow, there could be a paper published in the New England Journal of Medicine that says putting these two checkpoint inhibitors together improves survival, and all of a sudden the cost of care changes by $15,000 a month. So oncology is particularly challenging. We have ongoing running debates with ASCO, with John Cox, with very many people about whether drugs should be part of the model or not. And they are, and because we think there are opportunities for physicians to think about value in drugs, although sometimes you are stuck and you have to use certain drugs. We do, in the oncology care model, have what we call a novel therapy adjustment. And the idea of that is that we have a historical baseline period, and then we look at what's happening outside of OCM and non-OCM practices and saying, well, this is what's happening here, so we're going to adjust you up. So to make that more clear, you have a lung cancer episode, and outside of OCM, the cost of lung cancer went up by 10% this year. Well, we're going to change the baseline price, the target price, the benchmark price by 10%. So we're trying to make it, we try to make it as fair as possible to practices who want to participate and do participate. Oncology is hard because there isn't always necessarily a defined starting and stopping point. So that's why you created 6-month episodes. Those episodes do repeat or can repeat as long as you continue to get chemotherapy. And then in terms of what's going to happen down the road, my favorite expression these days is stay tuned. It's going to keep changing. I do have a day job to go back to after this, and that's what I work on. I think that oncology is hard. You said, well, a lot of things happen outside of the episode, and how do you do that? And one of the things that I came to appreciate when I came to work at CMMI about 4.5 years ago, is that there are things that two doctors can figure out talking in a hallway that don't work at the level of 150,000 beneficiaries per year, which is what OCM is, and even that's just 20% of fee-for-service Medicare. So one of the examples that often comes up is, well, why do you start with chemotherapy? Why don't you start with surgery? That's when the cancer care starts. And my point is, go look at the ICD-10 codes and look at how many masses of unknown significance exist. And if you say you're going to start with the surgery, how are you going to deal with the coding issues of a mass of unknown? My favorite code, I forgot which code this is neoplasm of uncertain behavior of uncertain location. I'm not sure how you get that, but there's a code for that. And so that's why we sort of have to, when we do models, we have to think about what works at the level of claims analysis and what works at the level of hundreds of thousands of claims per year.
You don't want to get me started on what I think about ICD-10, which
I would probably just say ditto.
Which I don't think has been all that helpful.
Well, so I mean, I'm going to just do a little thing here, which is, so I always, as an oncologist, right? So in ICD-10, this is non-CMS. This is not CMS speaking. This is cranky oncologist talking, right? We can tell you which quadrant of which breast a woman has breast cancer in. We can't tell you if she's ER/PR positive. We can't tell you she's HER2 positive in the coding system. In my world of pediatric oncology, I can tell you which bone there's a neoplasm in, but I can't tell you if it's Ewing sarcoma or osteosarcoma. So I think there are a lot of opportunities for improvements in the ICD-10 system.
For the recorder, Len Lichtenfeld, American Cancer Society. I think I'm channeling Larry and our last discussion, and actually impacting everything that's been said here, but I'm going to pick on Ron as well. In disclosure, I sat on a committee called the Relative Value Update Committee for CMS for about 24 years. Well, not CMS committee. I don't know what the right word, advises CMS on the payment models. Did that for 24 years. And I can't, and the last panel and this panel, everything we're talking about is impacted by payment policy. I mean, it just is impacted. And it's impacted by data that is so out of date and so irrelevant to the care of, I shouldn't say so irrelevant, but relatively irrelevant to the care of cancer patients. And we're building data on bad data when we come up with all honesty, because there are a lot of things in that payment model that have not been updated, that don't include technology, for example. I'm thinking about the EMR systems are not accounted for in the regular payment that someone receives at a level 2, 3, 4, or 5 code, modern technologies. So I won't belabor that point, but everybody who's had a comment here, it's limited how we can redefine the system, even the use of our lab technologies. The issue about doing genomic screening. So, for example, if you do the approved foundation test or whichever the Memorial, whatever those tests were, if you come back now and a patient has a progression with an EGFR mutation and they can't get a biopsy, you want to do a blood test, which is available and approved. MolDX has approved it. Palmetto, I know, has approved it, but you can't do it because they had the foundation test as the initial test. The CAR T therapy comes to mind as well. We have a cumbersome system in place today. Not what you're doing, Ron. This is not directed at you. We have a cumbersome system that affects a substantial number of cancer patients that is it's antiquated and non-responsive in coverage decisions to try to improve the care for cancer patients. So I think we've heard great ideas. And I think when it comes to technology, I want to be very clear. Some technologies are good. Some technologies are not good. Some technologies are going to offer us gee whiz stuff, but the fact is the application of that technology has not been studied. So I think we have I won't go on. There's a long list of things I could say. But ultimately today, payment policy is a big barrier. And you are optimistic, and I appreciate the work you're doing. I appreciate the work that you and your colleagues are doing at CMMI. But the vast majority of the issues we're facing are going to be limited. And in answer to your question, are we going to come back in 10 years? I probably won't be here to talk at the microphone in 10 years. I hope I am, because I can say I told you so. If we don't solve quickly at that level what we're doing for the care, again, of the majority of cancer patients, and of course those who are disabled as well, who fall into the Medicare system, we will not be able to make progress. All of the wonderful ideas won't count, because you can't get payment for palliative care, you can't get payment for nurse navigators, you can't get payment for end-of-life counseling, but all the things that we know make a difference and allow us to be to innovate and rethink what we're doing. And the care model is going a bit in that direction, but to get where we have to go, to redirect those resources. And by the way, I've been in a lot of alternative payment discussions. The drug thing is real. I have sat in conversations where the reinsurance people say, we will not touch that market. Now, maybe others will touch the market, but this one gave a pretty strong analysis saying it is too unpredictable for us to engage. So there are people out there who are talking about innovative ways to pay for costly, expensive care over time, and not just in oncology. So I'm always an optimist. I have stood at a microphone like Larry for decades. We keep coming back. I refer to what I call the Bozo the Clown phenomenon. If you remember, Bozo the Clown used to punch Bozo the. You look at me. You don't remember this? You punch Bozo, and Bozo bounced up, and we're not Bozos, but the reality is we keep coming back because we believe we can make a difference. Everybody in this room, that optimism is so key. It's so important. But if we don't get changes where it counts, and a better way to approach the rapidly changing oncology workforce issues, rapidly changing oncology technology, we're going to get stuck and we'll be in the same place 10 years. I wish you well, Ron. I hope people are listening, but I want to be optimistic. I hope you're right.
I'm just going to say two real quick things, and then people stop asking me questions and ask other people questions. So that's the beauty of a bundled payment model, isn't it, right? We give you a set amount of money, again, emphasis on the word fair amount of money, and you decide whether you want to do the foundation one testing a second time because the patient has progressed or not. And that's the beauty of it. It's no longer, I have to get approval for this. I got this pool of money. How am I going to spend it? It's under my control, interacting with a patient. And then the second thing I always say, which we say a lot in health policy, or I say a lot in health policy, is it's sort of like, I think Otis Brawley was talking about how life is third grade. Life in health policy is also kindergarten, right? One person misbehaves and the whole class doesn't get to go to recess. So a lot of times when we make health policy, it's for that 1 or 2% of people, whatever the percent is, who are going to take whatever rules are out there and they're going to abuse the system. And so we have to put rules in place to prevent that abuse. And just to sort of bring it to the real world, I always tell people, did you lock your car this morning when you left your car? Yeah, you did. Well, 1 person in 1,000 is going to break into it. 999 are going to walk by and leave it alone. But you still lock your car. Did you lock your house? You have for the same reason. So health policy, and it's unfortunate, but there are folks out there who are going to say, if we do this and this and this and bill it this way, then we can make some extra money. And, that's not a criticism. I mean, that's capitalism. But so we have to, look into that and say, all right, how do we have a lot of conversations at CMMI about gaming. How do we prevent gaming the payment system so that the right thing's done for patients? And that's where some of those rules come from.
That was a frightening referral to kindergarten.
Only because Larry was the one who usually caused the class not to go to recess.
I think we all remember that feeling. Like, don't say it, don't say it. Ooh, he said it, now we're in. I want to take us back kind of away from those topics for a moment while we wait for more of you if you have questions. I was thinking about getting back to the title of this workshop and thinking about resilience for providers, and also thinking about those human qualities like patient satisfaction, like caregiver satisfaction, and how those are definitely part of the value and quality equation. And Randy, you and I had some interesting conversations yesterday about this, about what keeps you in practice, what keeps patients satisfied with the care they receive. Would you like to share this with the group?
Thanks, Lisa. So I think that for any of us, for the work that we do, it needs to feel meaningful. And no matter how hard we work, if we have difficult patients or more patients than we can handle, if the interactions that we're having feel meaningful to us, if we know we're making a difference, if we know we're the person who can actually deliver the service, I think it gets us through the day. It gives us some satisfaction. I think that when we feel like we're wasting our time, that's when we feel like, that's when burnout comes. I don't think it's the total volume of work, although that's important. We need to do things that maintain our sanity and maintain our personal health. I think it's the quality of the work that we do. So I think that we need to figure out ways to remove the work that's not meaningful. I think in general, we have enough of everything in healthcare. We have enough doctors, I really think. They're not properly distributed. I think we heard from Brenda that we probably have enough nurses, but I don't think people are deployed in the right way. I think that there are equity and distribution issues, but I think we have enough of what we need. I don't think we're using it properly. And when we are using it properly, I think that we all feel terrific. We know we're working well together. I know for me, as a leader and as a physician, I love when the rest of my team feels good about the work that they do. I think that as leaders and members of teams that for me, one of the most meaningful parts of the work is enabling others to be successful and to feel good about their work and to see the value in their work. So I think that for me that gives resilience, and I think probably everybody gets that. And I think that we also need to make people feel valued in our work, valued in our cancer centers and whatever our workplace is. I think we always need to shine the light on the work that other people do and give them thanks.
You know, I think we didn't focus as much on the issue of burnout and resilience as we did many other factors that we talked about over the last day and a half. And burnout is a phenomenon that's been known about since the 70s. One of the earliest researchers was Christine Masloch, who studied first responders in the late 70s, early 80s, and she's studied other populations of caregivers. And she truly, and others who come after her, show that burnout is really related to a set of conditions. And, you know, I think in healthcare right now, we've been touching on those conditions, the payment system, technology that is not serving the patient or the practitioners well, and other things you can look at. These are the systemic reasons for burnout. And with that, unless we engage and make changes in our systems, I mean, I keep wondering, when are we going to go and protest to the EHRs and say, no more? How is it we've just accepted what's been handed to us? But that's another story. I touched upon just briefly yesterday, I want to bring this up because there is another phenomenon that now has been studied, and that's compassion fatigue. And compassion fatigue is very different. So some of the strategies with compassion fatigue, which is an introspective, an intrapsychic phenomenon, it's the exhaustion that occurs when you are constantly working with, in the case of the first responders, the trauma they see. In the case of us, patients who are going through the journey of cancer in all different ways and what's affecting them and their loved ones. That you can build resilience for. In the case of burnout, if it's true burnout, oftentimes the only solution is to leave because you're not able to change the conditions. So for an example, the APPs who have come from a system that allowed a certain kind of practice and move into a system where they're restricted and can't change that, may over time say, I can go elsewhere. The nurse who is in a facility that's going to do 4 10-hour days, but they find out that they're still there at 12 hours because of whatever the work is, and they can't get that changed, might not remain. So the strategies for resilience versus burnout are very different. But with resilience, there's a lot we can do in terms of ourselves and replenishing ourselves. And that's what you touched upon, Randy. Some of what you were talking about is more how you build the resilience, which really helps if it's compassion fatigue that you're dealing with.
I would really agree with that. There are certain things that we can control in the short term and others that we can't. So the frustration with payment systems and the requirements for documentation and people spending more hours doing things that they think of as pain in the neck chores versus what they came into the profession for, and working directly with patients. I think that there is so much that can be done, and it's part of this leadership training is to provide space for compassionate fatigue, for making sure that you're taking care of the well-being of your care force. This was a tough job and a tough field to be in before we had these other electronic challenges. So, and there was a lot of work done of how to take care of that workforce, and we can't lose sight of that. So I think it's you don't necessarily have to reinvent the wheel to make this happen. There are ways to do it that can really help to people find strength by being able to share their frustrations with their colleagues and work through those frustrations as best as they can. Once you admit that you're an adult in this world, there are always certain things that we can't change. And we can fight for change, but change is slow. But you can make the daily life at work more livable and more tolerable and actually supportive. So I think we have to incorporate that into the recommendations.
David Morris with SSM Health. First, one, I try to play nice in the sandbox. That's what I learned from kindergarten and third grade. Second, I'm going to first address the burnout issue. That's a real issue. National Academy of Medicine has done an enormous amount of work on it. ASH has actually included much of that in their statements, and they have a statement on National Academy of Medicine. This is something we can ask the other specialty societies like ASCO and ASTRO to put a clinical statement that's a low-hanging fruit onto the National Academy of Medicine resiliency site. That's very simple. I think the other thing that's important is feeling valued as a provider, feeling valued as a patient, feeling valued as a caregiver. I've been doing this for 20 plus years, and I still sit there and I tell my daughter, what other job can you be at that you can cure cancer and relieve people's suffering? And that keeps me going. Now, with regard to the whole group and with regard to the care force moving forward, I think it may be important to try to compartmentalize things. The reason why we put up with the EHR is it pays the bills and the margin allows us to do the mission. We are now moving from an area of margin versus mission to value and volume. Can we bend things in terms of service, education, research, finance, technology, and teamwork? Moving forward to provide some direction, can we look at doing, as Dr. Oyer mentioned, more with less, or more with what we currently have? One of the comments that was made by Dr. Cox was, can we look at Parkland and look at the cancer disparities? The programs are already there through the NCI to address those issues. Can we link in with the organizations like that? And what can we do with legislation to relieve some of the burdens and some of the barriers? That would be the other thing I would add to that list of service, education, research, technology. You can add legislation or legal. Thank you. And I'd like for anybody on the committee or the group up there to comment on how they could think about some very specifics to address coming out of this meeting.
Ideas? We'll give them a moment to think about that.
Well, I mean, you've just stated a couple of suggestions about what the professional societies could be doing. And we often do things, again, in our sometimes tunnel vision. But I think you've just challenged that across our specialties, we should be touching base and checking in with this and adding to what is there with the work group that's looking at the workforce resilience, not just cancer-specific workforce, but the healthcare workforce. That's a simple thing. You know, one of the things that came to my mind is, are there specific collaborations and initiatives that certain things might make some sense? And so how do we align the voice of physicians, APPs, both PA and nurses, nurse practitioners, to really have on a legislative agenda these issues that we're facing, across state, what have you. I think there's work that could be done there, for example, and that could be a recommendation, that the unity of the professional societies on that, and that would be several of the physician societies, and I think there's a couple of PA organizations, there's a couple of nurse practitioner, and there's ours, and there's a couple of nurse practitioner. Get people in a room and really look at how do we attack this problem that we're seeing out there, that this variance that even in the same state that Dr. Cox shared.
One of the things that we've done in our organization to raise the patient voice, both from a federal and state perspective, is to have data to validate the true patient experience. And I think from a professional perspective, if you were able to have data that shows across disciplines the challenges that practitioners are having in delivering optimal cancer care, that provides momentum. It's much more powerful than the one story or the one person who gets up, or somebody goes in representing the pharmacists and somebody goes to the Hill representing the nurses and somebody is representing the physicians through ASCO. It's much more powerful when you have data across your professions. So that takes money to do that. You need a database and you need a way to do that, but jointly you could probably figure out a way to elevate the voice from just being annoying, going in one by one, to actually having a unified. And you combine that with the patient voice, which we have that data, it's very powerful.
Lisa, I appreciate a pause to try to digest what Dr. Marth said. And I think what Hildy just said is really very important about starting with data and then starting with a patient voice or patient focus at the center. And then I think it takes leadership and clear communication about what we want to accomplish and why we want to accomplish it. We're all doing so many things and talking about everything from so many perspectives. And I think one of the things that Larry told us at the beginning of the workshop was no complaining. We need to have solutions. So we have to figure out what our priorities are. And then I think we all need to be saying the same thing. I think we need leadership. Bob spoke to this yesterday about creating a vision and coming up with solutions. I think we need to be very, very clear and learn to speak in a way that conveys a message built on data, but patient-centric, that doesn't talk about ourselves, that doesn't talk about the past, that doesn't talk about our hardships, that doesn't talk about the problems, but actually creates a vision for what we want to accomplish and some clear solutions for getting there. And then I think we need to get that through, as I said before, all of our training programs, our retraining programs, our community partners, and our research agendas. I really think we need to come together on the issue with a clear vision. And I think that's what the National Academy is going to help us to do with this workshop.
Thank you, Randy. Lee?
So maybe I'll just take an opportunity to vet out, Hildy, some of your recent questions and calls for data. So Lee Beamer again with the Association of Community Cancer Centers. I do have in hand some pre-publication data from a recent 320 member strong survey, specifically designed around issues of resiliency and burnout in the oncology workplace. It utilized the Mini-Z survey to address some of these concerns, and just a couple of statistics, I'll be brief. According to our members, again, 321 respondents, I feel a great deal of stress because of my job within oncology. 66% responded that they agreed or strongly agreed with that statement. My control over my workload is 27% said good, 37% said marginal or poor. Sufficiency of time for documentation, only 24% said good, and nearly 40% said marginal or poor. And 15% of respondents said their work atmosphere was either hectic or chaotic. And calm was at the opposite end of the spectrum for this particular question, and only 3.7% of respondents said that they were in a calm work environment, specific to the oncology multidisciplinary team, specific to the oncology workplace. And so to address, Randy, to some of your comments about what are some of those tenets that we can potentially organize ourselves around, we will be having a deep dive workshop at our next month's annual meeting with a multidisciplinary panel and then membership to address some of these. And we have at least to identify a couple of talking points addressed work after work and how we can reduce that to improve resiliency and decrease burnout. Alleviating workplace inefficiencies and potentially developing cultural readiness plans. So sort of this idea of, or conceptualization of self-care for our employees so that we are able to take better care of our patients because we're first taking care of ourselves, singular, and ourselves plural as part of a multidisciplinary team. So just some data too, and maybe some talking points of your own for different things that we can work on, and a call certainly to participate in the meeting so we can have a great, robust discussion. Thank you.
Yeah, hi, Neil Merple from Flatiron. I've really enjoyed hearing about the many technological solutions that folks have offered over the past day and a half to combat resilience and improve patient care. But one area that really hasn't been addressed, which I think is an important opportunity for application of technology, is around clinical trials. Clinical trials is an area of great job satisfaction for the healthcare team in terms of providing the most cutting-edge care. It contributes to patient care in terms of generation of new knowledge, but also there's evidence that participants in clinical trials are really getting the highest quality care. And yet many providers and sites of care don't take part in clinical trials, in part due to logistical issues and the burden for the site itself in taking part, and inefficiencies related to that. And I just want to make the point that technologies exist today that can improve the efficiency, reduce the burden of clinical trial participation for patients and the care team in terms of identifying patients for clinical trials electronically, data collection, monitoring through electronic health record systems, and follow-up as well. And I do believe that technology can get us closer to a world where clinical trial participation, research participation becomes more seamlessly integrated with clinical care, with routine clinical care, leveraging technology to do so. And I think that could help combat some aspects of the resilience problem that we face today.
Thank you, Neil, for that perspective.
I couldn't agree more, and I think there's certainly a value add to that that's recognized, at least in the oncology care model, for one.
I kind of thought about this before I said it because I know we're on live TV. But, I made a joke earlier about accreditation and nobody really laughed, and accreditation's not a joke. But sometimes we wait for the accreditors to tell us what to do, or we use the accreditors to get the things we need. But you don't have to wait for accreditation rules or for legislation to do what we know is right. And so I think that we have to push those boundaries and be irreverent sometimes in order to get the right things done.
Thank you, Ruth.
This is where I get to be proud of my tiny, tiny specialty of pediatric oncology, which is about 1,200 doctors in the U.S. I think we put about 60 to 70% of our patients on clinical trials in pediatric oncology, and I think it's 3 to 4% in adult oncology. And I think people talk about the barriers, and certainly technologies, can help. But I think it's also and this is not, really relevant to workshop. But I mean, I think in terms of clinical trials, it's a culture of what you grow up with, And in pediatric oncology, we're just taught that putting a patient on a clinical trial is the right thing to do. So, it's sort of different from the workshop perspective, but I mean, I think that's part of it has to be a cultural change in medical oncology, and that's how I think in pediatric oncology we've made as much progress as we have.
Thank you. Okay, one final remark. Go ahead, Courtney.
Well, this hasn't come up, and I'm just curious from the clinician's perspective about de-implementation and abandoning ineffective treatments, and whether that's an area of focus in your space, and also if that's something that could help reduce burnout and workload by kind of letting go of things like that. But I don't know what the debate is in this area.
Okay, one more.
Again, weaving things in, I do think there's interest in, because we all recognize that the art of what we bring sometimes brings a little bit of added on useless activities. I hate to come back to the reimbursement issues, but I think when you have more of a value-based model where you're one bucket of resources and you have to begin looking harder at what you do. Even the OCM has been a modest effort for us, but it really has shined a light on some of the non-value add services or processes that we do. Randy, you may have other thoughts about this.
Thanks, John. I certainly agree. De-implementation science, stopping doing things that don't matter, things that have greater harm than benefit, things that have unproven benefit or minimal benefit. I think that's really important. As John alludes, we're stewards of our resources, our people, our monetary resources, and we need to, I think, identify what really makes a difference, start looking for waste, and to be able to earn the right to use these expensive new drugs and new diagnostic studies. I think we really need to step back from the things that don't make a difference and shift our focus.
Thank you, Randy. I think we could have a whole workshop on implementation and then de-implementation science, for sure. I did want to give an opportunity, though, for Larry to tie things up. But before I do that, would you help join me in thanking our amazing panel here today?